I mean, I don't know what you all felt. I know maybe Europe and the States have had the greatest volume of publications in the past, and it seems like Asia's coming on strong everywhere we look. So I think we need to kind of get into high gear here. Thank you so much for your contributions. Our next talk is going to be by Dr. Brioschi. He's going to talk about sympathetic pain and fibromyalgia.
Okay. Okay, this is my last presentation today. I had finished, I will explain this logo mark. So let's go. Thermal imaging, sympathetic pain, and fibromyalgia. I explained something characteristic of infrared imaging of fibromyalgia. So it's possible to document fibromyalgia by infrared, but the diagnosis is a clinical diagnosis. There's criteria based for this. I'd like to talk about the mimic, what the disease that mimic is CRPS. So there's a lot of disease that can mimic this, and I would like to show you and explain this more clear. So the C-fiber mononeuropathy with peripheral nerve injuries, neurogenic thoracic outlet syndrome, plexus injuries, radiculopathy, post-herpetic neuralgia, spine tumors, all can mimic CRPS. Also acute trauma, post-traumatic injury, diseases, hypothermia, and Renault phenomena. They are some of them. The peripheral nerve injuries is possible to document by infrared more easy. It no hurts. The results are very similar of EMG, but the difference that you have early signs much before EMG, but are two different methods. One we are studying C-fiber, sympathetic fibers, and EMG, sensitive and motor fibers. Both are complementaries. So there are so much studies about this. Uematsu was American neurosurgeon that studied this, and he found a 0.2 degrees as normal, and when you have a difference more than 1.5, you in front of a neuropathy of limb with 98% sensitivity and 90% of specificity in this recent research. There are a lot of other research with in dental research with inferior alveolar nerve recovery by Lee and baby plexus paralysis recovery in this Japanese research. So this is a case of syndrome, tunnel carpal syndrome, when you see hypothermia, hyporadiation on the median territory of the right and left hand. You see that it's different because we have we don't have a similar anatomy. Sometimes we have variations between the nerves. This is another case of median neuropathy. Here is in the acute phase, because in acute phase the lesions becomes the dermatome more hot. Then you have a hyperthermia in the beginning and the acute phases, and after hypothermia. Okay, median nerve. You just put the hand this way, make the thermography, and you correlate with the clinics of the patients to close the diagnosis of median neuropathy. And there are some experimentals. You can do this using a local anesthesia. If you make blockage of ulnar or major nerve, you will have the same results. So thermography is fidedigna to diagnose of neuropathy, peripheric neuropathy. Okay, you can do in the clinicals or experimental, and it's very clear this. And this is very different from CRPS patients. Okay, the area of paresthesia is similar of the area of hyperthermia on thermography. We can also make a stress test to reinforce the diagnosis. If you have a doubt, you can do this. Put your hands in the cold water with gloves. In this case, we don't wet the hands. And this is the normal response. You have a hunting response. It's a hyperemic response. But in the neuropathic hand, you have a late or a very fast response. In this case, a neuropathy of ulnar nerve. Okay, so you can do static image or provocative test. There's no way to for litigation is very good, you understand? Because it's a very objective proof that there is a problem there, and you can correlate it with the symptoms of the patient. So we use this for worker compensations, on legal medicine, experts use this a lot to document this alteration. Also on trigeminal disease, this is a trigeminal neuralgia, and it becomes more cold sometimes. Okay, and other complex cases are in the neurogenic thoracic outlet syndromes. It's possible to see a hyperthermia on the local of compression. Sometimes could be a compression of a rib or muscle compression also, like scalenes and omohyoid muscles can compress the nerve, and you have a hot spot in the shoulder and a cold arm in the most of times in the ulnar part in C8 or sometimes C7, depends of the case. You can also do maneuvers to stress the patient and have this image much more better. Also for the back, as the Dr. Park explained, you can walk and make the image, or also you can say to patient to make flexions, and you see the dorsal and the leg, and again you do the image of the plantar. So thermography is not only taking pictures or stacked pictures. You can do provocative tests, mechanical tests, or cold stress tests. So it's not a case of CRPS also, because sometimes it's very difficult. You can do the same to study babies. It's a baby plexus injuries. Who will do an EMG on a baby? It's complicated. This. There are some ones that do, but it's very complicated. And monitoring this, and we have a motor changes also that can be easy evaluate. But with infrared, we have a much better and much more objective measurements of the recovery of the treatment that is being doing to the baby. The baby is doing the thermogram in his mother arms. Yeah, very interesting. And we would like to thank Dr. Zhang. And when we visit Korea, Dr. Parker also, that we learn a lot with them, with this team at Korea, because then we started to use their map, and it works very well. Today we teaching our medical students to interpret radiculopathy by infrared using their maps. I asked them to paint, draw it, study point 1, point 2 here, point 3. It's very easy to replicate this, and it's like a radiology. You must do training to see and how to measure. So this is a case of L5 radiculopathy. We use analyze the back difference. You see here a heat flame on level L4, L5, associated with asymmetric buttocks and calves and in the leg. In the plantar. So it's in the same way of this presentation here in the L5 radiculopathy. So take what Professor Zhang showed here. There are papers published on that, and just follow in, and you do this diagnosis also. And this is S1 radiculopathy. You see, it's irregular image with a heat flame on level L5S1, asymmetric buttocks, asymmetric legs, and hyperthermia on the calf, on the plantar. Sometimes in the plantar it becomes hotter, not cold. It changes because the receptors, neuroreceptors are different on the plantar foot. This is a radiologist that he didn't believe on thermography. I don't believe on this, but he was with back pain when he came with us, and we did image, and he said, "Oh, yeah, I really have S1 radiculopathy." So then he goes to the MRI, confirmed he has afraid of MRI. But after the thermography, he did the exam. Claustrophobia. And this is another case, very interesting, on the postherpetic neuralgia. And it's very interesting because these two hotspots are not trigger points. This one, it was a melanoma. So thermography has some pitfalls that we must be careful. It's, I think it's much more a medical exam because you have a vascular disease, tumor diseases, and neuropathic disease, all in the same image. So you have to be skilled to interpret this image and study a lot of different points of medicine. Okay, this patient was stopped his treatment for neurology and went to oncology treatment. And here's a case of ilioinguinal neuroma after appendectomy. Abdominal pain, nobody knows about this. We make this picture and we saw a very hot spot, but it's 1 degree, 1.5 degree in the local of incision of appendectomy. 3 years of pain. Nobody didn't know about this. This is another interesting case. When we did this, it was a man only with a back pain. But he has asymmetric thermography, asymmetric limbs thermography. When we have asymmetric without pain, you must be careful because most of times could be tumors, medullary tumors, spinal tumors, and it was confirmed after it was a spinal tumor. So it's not CRPS and it's not a radiculopathy, but it's spinal tumor. So it's a medical exam. We must be careful. This is another patient with pain on the shoulders, on the cervical. You can see a muscle strain here, myofascial, asymmetric, inflammatory on the shoulder. But when we did the full body, and you saw the warm hands without pain, or hand without pain. It was not a CRPS, but it was a spinal tumor, metastasis of prostata tumor. So we must be very careful because we have the picture and we must associate with the clinic of the patient. This is another patient after a post-stroke pain. You see half body is all symmetric, the face, the arm, the legs. So you have he had a stroke on the right side and make this left side asymmetric thermal partner. This is another patient, very interesting case with abdominal pain, 4 years and a half with abdominal pain, nobody knows. All exams passed to all gastroenterologists, and thermography showed this cold area on the abdomen, and if we didn't do the full body exams, we will not see this. You see cold here, is asymmetric, the leg, asymmetric leg. He has half a body asymmetric, so the pain was a central nervous pain. It's similar to before the case, the anterior case. So some patients with central pain, sometimes the pain are localized, but the source is central. And we can saw just doing the whole body thermography, and so it was a asymmetric in this case. So another patient seated with a full body imaging, and you can see asymmetry on the hands and the legs is also a central neural pain. So you do diagnose and you could do monitoring of this case, this complicated case. The patient that goes to thermography are complicated case. As Professor Park said, 15% of patients go to thermography. And which patient is not complicated with pain? Most of them, because they have a lot of disease at the same time. This is experimental study that we did. We also do experimental, and we make a ischemia of the carotid clamping and release it after 1 day, and it reproduces the same effect of hypothermia on the contralateral side of the animal. So this is physiology. You can reproduce it in the laboratory and see in thermography. So what do we discuss about thermography? Just to know the physiology, okay? This is cases of asymmetry in the eyes. Here's in the trochlear artery that is comes from ophthalmic and comes from carotid artery. So it's a very asymmetrical. So these patients are patients with obstructions on carotid systems. Okay, we don't see carotid here, but here in the inner eyes. Again, difference. Again with 0.5 degrees. Some patients that have more than 0.5, if they don't have pain, if they don't have any symptoms, they have a high risk of stroke. They must be investigated by ultrasound. I can't confirm it's obstruction, but I can say he has a high risk because the astrocerebral is compromised. Sometimes he has a good flow in here, but here is different. So it's a cardiovascular risk in this case. But we must be careful again because there's another situation we call cold patches. Some patients with migraine, vascular headache, has a cold patch without this difference here, or sometimes they have this difference, but have a cold patch that's very prominent on patients with stroke, with migraine. But it's not necessary to have the headache to have these signs. Patients without headache have these signs also, like a mark, specific mark. Again, patient with migraine. In this case, he was not with pain. Pain was 0. Okay. And another case. So it's very, very interesting this. I don't have time to explain the physiology, but it's I give to you to study this, to looking for headaches and vascular difference about. Okay, and as I said, most patients with pain have complicated disease, mixed types, with a radiculopathy, also with fibromyalgia, and dependent eyes, insomnia disturbs. Okay, here again another case, sleep disorder. Nobody will forget this. The fibromyalgia syndrome associated with thermoregulation disorder. Maybe it could be a sympathetic dysfunction. Nobody knows yet what causes, what's the source of fibromyalgia. But it's much more a neurological disease than a rheumatological disease. It's changed the things. Patients with spinal cord trauma has symmetrical, but if hypotonia and vasodilatation of the legs and arms depends on the level of the trauma. It's a trauma. Patients with fractures, maybe sometimes confusing with CRPS. So in this case, if you make the stress test, we will see that we have a vasoconstrictor